Hello friends, welcome to my channel. I am Dr. Himanshu Gupta and in this video we are going to revise the basics of ECG, the important ECGs that we should know. First, in this video I will be explaining you a little about the ECG and then I will be showing you the ECGs. You will try to answer them and then again I will discuss the answers. So let us begin friends. So first we will discuss the normal values. How do we calculate the heart rate in ECG? We calculate it by 300 divided by RR interval. RR interval we take the number of large boxes. Suppose we have to calculate the heart rate in this ECG. The number of large boxes between two RR interval is 4. So heart rate will be 300 divided by 4 equal to 75. So 5 large boxes is equal to 1 second. One small box is equal to 0.20 second. 5 small box is equal to 0.20 second and one small box is equal to 0.04 seconds. So we need to know the number of seconds of one small box because we will have an idea about what is the time duration of each wave. So there are three. So first we will discuss about the P waves. P waves comes before the QRS complex. Their normal duration is from 0.06 to 0.12 second. They are positive in leads 2, lead 1 and lead AVF and lead V2 to V6, and they are variable in lead 3 and lead AVL, and they are negative in AVR and biphasic in lead V1. So what do you understand by biphasic? Biphasic means this. Okay, so I will show you. So as you see, as I told you that they are positive in lead they are positive in lead V4, V2 to V6. So here they are positive. In lead V1 they are biphasic. So in lead V1 they are biphasic, and in lead AVR they are negative. So this is an important point that you should know about P wave. So the PR interval, you should know the normal PR interval. Normal PR interval is between 0.12 to 0.20 seconds or 3 to 5 boxes. P wave represents atrial depolarization. The normal QRS complex. The amplitude varies from each lead. The normal duration is from 0.8 to 0.10 second. Friends, we have to know the normal values, then only we can find the abnormal things. ST segment. You have to know that ST segment is isoelectric. And you can see from here the normal duration of QRS complex is 2 to 3 boxes, 2 to 2.5 boxes. Okay, so the normal duration is 1, 2 and 2 to 2.5 boxes, which stands for 0.8 to 0.10 second. And also you have to see that as you move from V1 to V6, the R wave increases, the positive R wave increases, and the negative S wave decreases. So here S wave is more prominent. S wave. So as we move from V1 to V6, the R wave increases in amplitude. Okay, so this was about QRS complex. QT interval. QT interval is between 0.36 to 0.44 seconds, or you can remember it by 9 to 11 boxes. T wave. T wave amplitude is up to 5 mm in leads 1 to 3 and up to 10 mm in precordial leads. Up to 10 mm in precordial leads, or it is roughly half of the R wave. Half of the amplitude of R wave, in which T wave is positive. Okay, so what are these V1 to V6? V1 to V6 are the chest leads. They are horizontally placed, and they tell mostly about the ventricles. Okay, so this is how they are arranged: V1, V2, V3, V4, V5, V6. V1 to V2 represents septum. So this is important because when we will study MI, when we will see the ECG of MI, so if we get ST elevation in V1 and V2, it means it is a septal MI. If we get ST elevation in V2 to V4, it is anterior wall MI, and if we get elevation in V5 to V6, it is lateral wall MI. Okay, now the limb leads. So limb leads are of two type: bipolar 1, 2 and 3, and unipolar AVL, AVF, AVR. So this is their direction: AVF, AVL, AVR, and then lead 1, lead 2 and lead 3. Basically 2, 3 AVF represent inferior wall of the heart, and if there is MI in the inferior wall, we see changes in the 2, 3 AVF leads. So friends, in order to get our questions correct in ECG, this is how we will proceed in ECG. First, you have to calculate the heart rate, and then you see the rhythm, whether it is regular or irregular. Then you see the P wave, in lead 2, and you see whether every P wave is followed by a QRS or not. And sometimes there is absence of P wave also. You see whether P wave is present or not. And you also see the height and width of the P wave. It is important when we study the atrial enlargement, left atrial enlargement and right atrial enlargement. Then PR interval. You see the PR interval, whether it is prolonged or whether it is decreased. Then you see the QRS interval. Again, you see the QRS complex is narrow or it is broad. Then after moving to QRS, you see the ST segment, whether it is elevated, whether it is normal, or whether it is depressed. Okay, then after that you will see the T wave, whether the T wave inversion is there or not. Okay, so why do we need to do all these things? Now I will give you, first I am giving you in brief about what we need to see in the ECG and why do we need to see these things. We calculate heart rate because heart rate will tell us whether it is a bradycardia or tachycardia. We need to see the rhythm. If the rhythm is irregular, then we will mark the option as atrial fibrillation. Then we see whether the P wave in lead to every P wave is followed by QRS or not. Why? If 2 to 3 P waves are followed by QRS, and we see bradycardia, okay, or we can say that every P wave is not followed by QRS, then we will see whether it is bradycardia or tachycardia, whether heart rate is more than 100 or less than 60. Okay, so if it is bradycardia, we will think of heart block, whether it will be type 2 or type 3. But if it is tachycardia, then we will think of atrial flutter. So we have to see every P wave is followed by QRS not. If it is not, then we will see the heart rate. If it is bradycardia, then it will be heart block. If it is tachycardia, then it will be atrial flutter. And if P waves are absent, friends, how we will differentiate? Then if P waves are absent, we will see in paroxysmal supraventricular tachycardia or atrial fibrillation. But in atrial fibrillation, we will see an irregular rhythm. So this is how we differentiate PSVT from AF. Okay, friends. So hope this is very clear. Atrial flutter. It will be more clear once we see the ECGs. PR interval. We have to see whether it is increased or not. If the PR interval is increased, we see increased PR interval in heart block, ECGs of heart block, beta blocker, and in which hypokalemia. These are the ECGs in which we see PR interval is increased, and PR interval decreased we see in Wolff-Parkinson-White syndrome and Lown-Ganong-Levine syndrome. So QRS is broad in Wolff-Parkinson-White syndrome, and we see delta waves. And in Lown-Ganong-Levine syndrome, the QRS is normal. Friends, just listen these things now, and I will show all these things on the ECG as well. QRS interval. If the QRS interval, we have to see whether it is narrow or broad. If it is increased, it is seen in right bundle branch block, left bundle branch block, or you will think about ventricular arrhythmias, idioventricular rhythms, or ventricular tachycardia or fibrillation. Okay, and Wolff-Parkinson-White syndrome also QRS is broad. And one more condition where QRS is broad is hyperkalemia. Okay, friends. So now then we move on to the ST segment. We see ST segment. If there is any elevation, then it can be ST elevation MI. So if there is V2 to V3, V4, then it is anterior wall. If it is V1 to V6, then it is anterolateral wall MI. If 2-3 AVF are involved, then it is inferior wall MI. Other conditions where we see ST elevation, it is pericarditis. So how do we differentiate between the elevation ST elevation in pericarditis and ST elevation MI? In pericarditis, the concavity will be upwards. And it will be seen in all the leads. But in ST elevation MI, the there will be convexity upwards, okay friends, there will be convexity upwards. So, and also it will not be seen in all the leads, okay, and this is called as Pardee sign. And also another condition where you can see ST elevation is ventricular aneurysm and myocarditis. So friends, if you see the ECG carefully, you will be able to identify all these things. And ST depression is seen in non-ST elevation MI and digoxin use. So now the T waves. We have to see whether any T wave inversion is there. If T wave inversion is there, it can be it is due to, if T wave inversion is there, it is due to angina, MI and strain, due to strain pattern ECGs, okay, strain, when there is strain on the heart muscles. And tall T wave is seen in MI and hyperkalemia. So how do we differentiate between the tall T waves of MI and increased potassium? In MI we will see hyperacute T waves, but in hyperkalemia we see peak T waves. See, the peak is formed, but in MI there are no peaks. I will show you this on the ECG as well. Now the QT interval. We have to see whether there is any increase in QT interval. Increase in QT interval is seen in congenital conditions such as Romanov-Ward syndrome. Call it as congenital QT prolongation, Lang-Gervell-Nelson syndrome. The drugs which cause QT prolongation are procainamide, ibutilide. Gatifloxacin, levofloxacin are antibiotics. Procainamide and ibutilide are antiarrhythmics. Antihistamizole, anti-allergic drug. TCA, antidepressants. Also decrease in calcium causes QT prolongation. So remember that calcium has an inverse relation with QT interval. When the calcium increases, the QT interval decrease, and when the calcium decrease, the QT interval increases. Okay, so now coming to the ECGs. So now you will identify the ECGs and you will pause the video. And you will try to identify the ECG. Friends, what do you see in this ECG? So you can pause the video here and friends, what do you see in this ECG? Normally the patients will come with chest pains, they will come with breathlessness, so I'm not giving you the clinical situation here. So the answer is in this ECG we see peaked T waves. These are seen in hyperkalemia. And what do you see in this? Friends, you can see the ST segment elevation here, and also hyperacute T waves. See, they are not peaked, and they are seen in MI. So V1, V2, V3 and V4 are involved, so it is an septal wall MI, anteroseptal wall MI. So what are the changes on ECG we see in hyperkalemia? It is widened QRS interval, widened QRS interval, wide and flat T waves, wide and flat P waves, tall peak T waves, prolonged PR interval, and in the end we see sine wave pattern. Sine wave pattern. So the changes, ECG changes of hyperkalemia are very important. In hypokalemia, friends, what is this ECG? So in this ECG you can see the U waves. So this is an ECG of hypokalemia. Okay friends, so now you will be identifying this ECG. You can pause the video here, try to identify the video. What you will do, you will first calculate the heart rate. Then you will see the P waves, then you will see the PR interval. You try to see the T wave, then whether every P wave is followed by QRS complex, So I think you must have got the answer by now. Since first we will calculate the heart rate. 300 by 2 is equal to 150. So the answer is sinus tachycardia. Okay friends, so now moving on to the next ECG. Try to identify this ECG. You try to see first you calculate the heart rate. Again the same steps, calculate the heart rate, then see the P waves, whether it is followed by a QRS complex, then you see the QRS complex, then QT interval, then T waves. Okay friends, so by now you must have got the answer. There are no P waves in this ECG, so the answer is paroxysmal supraventricular tachycardia. Or you can say it is a junctional rhythm. Heart rate is approximately 100. Junctional rhythm. Junctional rhythm are the ones which originate from the AV node. So we don't see any P waves in this. So if the heart rate is less than 50, then it is an intrinsic junctional rhythm. If it is 50 to 100, then it is called accelerated junctional rhythm. And if it is greater than 100, it is called junctional tachycardia. Okay friends, so moving on to the next ECG. So again the same steps, you calculate the heart rate. It is approximately 1 2 3 4 75. Heart rate is 75. We cannot see any P waves. No P waves. So if there are no P waves, what do you think friends? We move on to the QRS complex. The QRS complex is around one box. It means QRS interval is prolonged. And QRS interval is prolonged in ventricular arrhythmias. So it is a idioventricular rhythm. idio when the QRS is prolonged, it is mostly an idioventricular rhythm. What is the heart rate? 1 2 3 4. Heart rate is 75. So idioventricular rhythms are again of three types: intrinsic, when it is around 40, heart rate is around 40; accelerated idioventricular rhythm. Accelerated idioventricular rhythm is heart rate is between 40 to 100, and idioventricular tachycardia is when heart rate is greater than 100. Remember that accelerated idioventricular rhythms are seen in post myocardial thrombolysis. Post myocardial thrombolysis. Okay friends, so if the QRS is prolonged, you will think about a ventricular pathology. Okay friends, so now moving on to the next ECG. What do you see friends here? What do you see? You see the heart rate 1 2 3 4 75. Then P waves. Normally the P waves is between around 2 to 3 boxes. Around 3 to 4, 2 to 3 boxes. But in this we see that ECG. In this ECG we see that P wave width is increased. P wave width is more than 2.5. So when P wave width is more than 2.5, it is left atrial enlargement. In lead 2 we see an increase in the width, and in lead V1 we see that the negative peak of the left atrium is increased. The negative height of the left atrium is increased, and it is called P mitral. So the negative component of P wave, width cross depth should be greater than 0.04 mm second. This is called as Maury's index. So it is a little tough to remember. Just remember that if P wave width is greater than 2.5, I was talking about the height and the width of the P wave, so this is the importance. So moving on to the next ECG. What do you see friends here? You can pause the video, and I will begin on to the solutions. So this is the complete ECG. So the arrow is pointing here. It is pointing on to the P wave. When the P wave height is more than 2.5, it is right atrial enlargement. Okay friends, so this is the importance of P wave height and width, and it is called P pulmonale. Okay friends, and it is characteristic in patients of COPD. So moving on to the next ECG. So the arrow is, you can pause your video. So the arrow is pointing here. What do you see friends? So this is our delta waves. These are seen in Wolff Parkinson White syndrome. You can also see that PR interval is decreased. PR interval is decreased. So PR interval is decreased in Levine syndrome, Levine syndrome, and WPW syndrome. But in Levine syndrome, the QRS complex is normal. And the conduction is through the James pathway. If this is the heart, this is the AV node, the conduction is through this pathway. In LGL, in WPW syndrome, the conduction is through an accessory pathway through the ventricles. It is called as Kent pathway. And the QRS is increased in WPW syndrome. Okay friends, now moving on to the next ECG. What are the findings that we see on this ECG? What are the findings, friends? So in this ECG, we see that in lead V1 the QRS is prolonged. So when QRS is prolonged, what causes we think? We think about the ventricular causes. Which causes did I say you? Right bundle branch block, left bundle branch block, then ventricular rhythms. Okay friends, so here we see this is a characteristic right bundle branch block. Why friends? Why? Because you can remember it with the mnemonic marrow, where M stands for M pattern in V1 and W stands for W pattern in V6 and R for right bundle branch block. Okay friends, so this is the right bundle branch block. What do you see in this ECG, friends? What do you see in this ECG? Friends, this is a characteristic ECG of left bundle branch block. So how do you remember it? You remember it with the mnemonic William, where M stands for M pattern in V6, and W pattern in V1, and L for left bundle branch block. So you see here, you see a slight M pattern. So this is left bundle branch block. Okay friends, so here they have formed the characteristic left bundle branch block. It is forming an M pattern. Okay, and we see a deep S wave in V1 in left bundle branch block. So moving on to the next ECG. What do you see, friends, in this ECG? What do you see? So in this ECG, you have to comment upon the hypertrophy, whether it is an RVH or LVH. Friends, you see the length of the R segment, in V1. See, in this ECG, if you see the V1 in this ECG, normal ECG or left bundle branch block, the R is very small. R is very small. It is almost negligible. Okay. So if we compare it from a normal ECG, friends, this is a normal ECG. You see the height of V1. Height of V1. It is almost approximately one box. But if we see in this ECG, the height of V1 is approximately two boxes. Approximately two boxes. So when the height of V1, height of R wave in V1 is more than 7 mm, it is right ventricular hypertrophy. Right ventricle hypertrophy. Okay, friends. So moving on to the next ECG. What do you see, friends, in this ECG? So this ECG is characteristic for left ventricle hypertrophy. Left ventricle hypertrophy. The criteria for left ventricle hypertrophy is more than 5 boxes, 1 2 3 4 5 in V5 or V6, R wave more than 25 mm in V5 or V6, or R wave plus S wave in V2, R wave in V5 more than 35 mm. You will see in this that V2, there is a very negative V2. This is due to LVH, left ventricular hypertrophy. So friends, now you will tell me the axis deviation in this ECG. How do you calculate the axis deviation? So first you try to calculate and then I will tell you the answer. So we calculate the axis deviation by seeing the lead 1 and by seeing the lead AVF. By seeing the lead 1 and by seeing the lead AVF. If we have a reaching pattern, what do you understand by reaching pattern? In lead 1 is negative and lead AVF is positive, then it is a right axis deviation. But if we have a leaving pattern, in lead 1 it is positive and in lead AVF it is negative, then it is a left axis deviation. Okay, so we see that in this lead 1 is negative and lead AVF is positive, so it is a reaching pattern. So reaching, R for reaching, R for right axis deviation. Friends, you will identify the special wave in this ECG. Special wave, you can pause the video. The special wave in this ECG is Osborn wave. Osborn wave is seen in hypothermia more than hypothyroidism. You remember just hypothermia for Osborn waves. Okay, so tell the axis deviation in this ECG, friends. Axis deviation in this ECG. So you will see the lead 1 and you will see the lead AVF. Are they reaching or are they leaving? What is? So they are leaving. So it is a left axis deviation. So which drug causes this? Friends? You have to identify. So this is a characteristic ECG called hockey stick pattern, and it is seen in digoxin use. So in digoxin there is ST depression and T wave inversion. So this is how you get a hockey stick pattern. Another characteristic ECG found in digoxin use is ventricular bigeminy. Friends, you will identify this ECG. I have put one question on this also. Okay. So coming on to the next question. So you will try to identify again this ECG. You will follow the steps of heart rate, P wave, QRS, QT, T wave. Okay. You can pause the video and I will tell you the answer. You see friends, this QT interval, I told you that the normal QT interval is between 9 to 11 boxes, but in this it is more than 11 boxes. So what is this? It is prolonged QT interval. It is seen. What are its causes? It is congenital. It is due to drugs like procainamide, estempizole, gatifloxacin, tricyclic antidepressants. Decrease in calcium. So hypocalcemic ECG will look like this, in which the QT interval is prolonged. Okay. So friends, what is this characteristic ECG? What do you see? You can pause the video. These are epsilon waves. It is seen in arrhythmogenic right ventricular dysplasia. Okay friends, so moving on to the next ECG. This is again a characteristic ECG. You can pause the video. So try to identify. So this ECG is, I have already marked. So there is ST elevation in segments V1, V2 and V3. Also you see an M pattern that is formed in V1. So it is a characteristic ECG of Brugada syndrome. So in Brugada syndrome you will see elevation in V1, V2, V3, a right bundle branch block pattern, and it is due to defect in the sodium channel SCN5A defect. Okay. So moving on to the next ECG. So this is an ECG of short QT interval. You see, a normal patient, the QT is around 9 to 10 boxes, but in this we see it is 1, 2, 3, 4, 5, 6, 7 boxes. So QT interval is decreased and it is decreased in increased calcium. That can be due to hyperparathyroidism. Okay. Now moving on to the arrhythmias, I will talk a little bit about arrhythmias, and then we will try to identify the ECGs. So the arrhythmias are of two types: bradyarrhythmia. For this you will identify by the heart rate. Okay. So once the arrhythmia is identified, you will see whether it is arising from SA node or it is arising from AV node. Okay, whether arrhythmia is due to defect in the SA node or it is due to the defect in AV node. So let us begin. So in AV node you will see there are heart blocks. It is of first many types: first degree heart block, second degree heart block, and third degree heart block. Third degree heart block is also called complete heart block. Complete heart block. So friends, we need to know how we differentiate between all of them. How we differentiate between all of them. In first degree heart block, there will be prolonged PR interval, PR interval, but each each P wave will be followed by a QRS complex. P wave will be followed by QRS. P wave followed by QRS. Okay. In second degree heart block, it is of two types, type 1 and type 2. Type 2, type 1 and type 2, it is due to intermittent failure of conduction from atria to ventricles. In type 1, the PR interval gradually prolongs. The PR interval gradually prolongs, and then you see a drop beat. Here the P is not followed by QRS. First the PR interval gradually increases, then it is followed by an absence of QRS complex, and it is called as Wenck-Bach phenomenon. Wenck-Bach phenomenon. So this is Mobitz type 1 block. Now we'll study Mobitz type 2. In Mobitz type 2, the difference is that the PR interval remains constant. PR interval remains constant, and after some time you will see that P wave is not followed by QRS, but PR interval is constant, it is not increased. This is Mobitz type 2. In third degree heart block, there is absolutely no conduction from atria to ventricles. So atria have their own rhythm and ventricles also have their own rhythm. So there is no relation of QRS complex with the P wave, and because QRS complex is formed due to the ventricle contraction, the QRS is wide. And you have to remember that every RR interval is equal, and every PP interval is equal. But PP interval is not equal to RR interval. PP interval, because PP interval is due to atria and RR interval is due to ventricles. Ventricles have their own heart rate around 40 and atria have their heart rate around 80. Okay. So now moving on to tachyarrhythmias. It can be sinus tachycardia originating from the SA node. We have seen the ECG of sinus tachycardia, and then it can be atrial tachycardia. Atrial tachycardia can be of unifocal atrial tachycardia or multifocal atrial tachycardia. Multifocal atrial tachycardia is a signature tachycardia of hypoxia. Then you can see atrial flutter. In atrial flutter you see sawtooth waves, and you have to differentiate this atrial flutter from PSVT. In PSVT there are no P waves. Both have tachycardia, but PSVT does not have P waves. Atrial fibrillation, it is due to individual atrial fibers are synchronizing in an contracting in an asynchronizing pattern. They are contracting, they are sending signals in a asynchronous pattern. Okay, so you can identify it has a very characteristic ECG. You will find irregular RR interval and absent P waves. absent P waves and irregular RR interval. Okay, so we have this ECG. I will show you this ECG. You should know the treatment part of. Friends, how do we treat heart blocks? How do we treat heart blocks? Treatment of heart blocks is by pacemakers. But if there is any cause, if there is any abnormality, first you will treat that. Once you have treated that, then you will put pacemakers for heart block. So treatment of atrial fibrillation in unstable patients, you will give DC shock, and in stable patients you will first give beta blocker. If the patient is asthmatic, then you will give calcium channel blocker. Okay, this is to prevent tachycardia. Okay, and if it is refractory, the patient is refractory, then you will give digoxin. Now you have prevented the tachyarrhythmia, but you have to convert atrial fibrillation into sinus rhythm. So for that, either you will give DC shock or abutolite. But if atrial fibrillation is for more than 48 hours, then there is chances of left atrial thrombus. So first you will rule out left atrial thrombus through transesophageal echo. Okay. Now moving on to PSVT, we have already discussed PSVT. It is sudden onset and sudden cessation. P wave is absent, and how do you treat in unstable patient? In unstable patients, you give DC shock, and in stable patients, you give adenosine. Adenosine is the drug of choice for PSVT. Okay. So now friends, you will identify the ECGs. So in this I will show you all the ECGs together. You can pause the video, and then in the end I will give you the answers. So identify this ECG. You can pause the video. You can see the answers later on. Question number 5, or you can write down the answers in your notebook. Question number 6, question number 7, question number 8, question number 9, question number 10, question number 11, question number 12, bidirectional ventricular tachycardia is seen in question number 13. So we will discuss these 13 ECGs now. Friends, in this ECG you will see that PR interval is prolonged. Normally it is between 3 to 5 boxes, but here it is more than 5 boxes. But every P is followed by a QRS complex. So it is first degree heart block. Okay, every P is followed by QRS, you can see. Moving on to the next ECG, we will first mark P waves, Q wave, QRS. T wave, P, QRS, T, P, QRS, T, P. So friends, we see that PR interval is constant. PR interval is constant. But we see that this P wave is not followed by QRS. So it is a second degree Hart block. Second degree Hart block. Type 2. Why it is not type 1? Because in type 1 the PR interval is gradually increasing. PR interval is gradually increasing. So moving on to the next ECG, we will mark the P waves. P waves, P waves, P waves, P waves, P waves, P waves. And one P wave is merged with incident. Friends, do you see, and you see the RR. P waves are not followed by QRS. Are not followed by QRS. Okay, so definitely it is a Hart block. So, and every, but you see the PR interval, it is varying. First it is increased, then it decreases. So it is a variable PR interval. It does not has any pattern. But one thing you see, friends, the RR interval. The RR interval is constant. RR interval is constant. The PP interval is constant. The PP interval is constant. So this is a third degree Hart block. Why? Because every P wave is not followed by QRS, and PP interval is equal to PP interval, and RR interval is equal to RR interval, and RR interval is not equal to PP interval. So you understand the points, friends, which I mentioned earlier in this video. So moving on to the next ECG. This is PR interval. You see, PR interval. It is gradually increasing, and you see this P wave. This P wave is not followed by a QRS. So this is second degree Hart block. Friends, first you will see that whether P wave is followed by QRS or not. If PR interval is prolonged and every P wave is followed by QRS, then it is first degree. Okay, then you see whether are there any drop waves or not. Okay, so if there are any drop waves, every P is not followed by QRS, and then you have to decide between type 1 and type 2. Okay, in type 1 there will be increasing PR interval, but in type 2 it will be constant PR interval. And in complete Hart block you will see a variable pattern. Now identify this ECG. P wave, Q wave, P wave, Q wave, P wave, Q wave. What is the heart rate? 1, 2, 3, 4, 5, 6. 300 divided by 6 equal to 50. Friends, this is an ECG of sinus bradycardia. You see the PR interval is also normal. Sinus bradycardia. Okay, so identify this ECG. We have already seen this ECG. You should be able to identify no P waves, an increased heart rate. So it is PSVT, PSVT. P wave, two P waves not followed by a QRS complex. There is tachycardia. So this is a sawtooth pattern, sawtooth pattern, sawtooth pattern seen in atrial flutter, atrial flutter. Friends, in this ECG you will see that RR enter, you cannot see, there are no P waves, no P waves. Okay, and you can see the RR interval is varying. RR interval is varying. So this is a characteristic ECG of atrial fibrillation. Friends, I will tell you one important thing. In tachycardias, what you will do, you will see that whether P wave is present or not. P wave is present or not. Okay. If it is present, then it will be atrial flutter, and if it is absent, it will be PSVT. Okay. So this is a very simple thing. You will see the P wave and you will see whether P wave is present or not. So if P wave is absent and it is a tachycardia, then it is PSVT, and if it is present, then it is atrial flutter. P wave absent is also seen in atrial fibrillation. So how you will differentiate both of them? By the rhythmicity. Okay. Also P wave will be present in sinus tachycardia. But how will you differentiate between them? Each P wave will not be followed by QRS in atrial flutter. Okay. And if it is wide, QRS complex is wide, then these are ventricular arrhythmias, like ventricular flutter, ventricular fibrillation. So friends, what is this ECG? You don't see any P wave in this ECG. The QRS is prolonged. So this is a typical ECG of ventricular fibrillation. What is the treatment? In unstable patients, we give DC shock. In stable patients, we give amiodarone. So moving on to the next ECG. Friends, what do you see in this ECG? You see that there is ST segment elevation of 2, 3 and AVF. So it is a inferior wall MI. Okay. So now moving on to this ECG. So this is you see that there is ST segment elevation in V7, in V8 and V9. So ST segment elevation in V7, V8, V9 is seen in posterior wall MI. Okay. So moving on to this ECG, you see that the length of the R wave is changing. So this is the characteristic ECG of electrical alternance. and it is seen in cardiac tamponade or pericardial effusion. Okay friends, so coming on to the last question, bidirectional ventricular tachycardia. It is due to digoxin, also called ventricular bigamy. It is a normal QRS complex is followed by premature ventricular complex. Normal QRS complex followed by premature ventricular complex. Ventricular by Gemini. So thank you friends for watching this video.